In the first lesson, we learned what are the few most common bacteria that cause almost all infections that we see in practice. Now that we know what bacteria we are targeting, you will have absolutely no problem mastering antibiotics. Starting with the first mass-produced antimicrobial drugs, penicillins, drugs that we use all the time. Amoxicillin, amoxicillin-clavulanate, and piperacillin-tazobactam, among others, right? You will see that it's really not rocket science, as long as we demystify all the unnecessary and confusing stuff that you are likely to find in your textbooks. So, before we continue, let's first make sure that you don't get confused by terminology here. Penicillins are beta-lactams, just like cephalosporins, carbapenems, and monobactams. All beta-lactams share a similar structure and the same mechanism of action, which we'll get to in a minute. The core of their structure is a beta-lactam ring, which looks like this. That is what they all have in common, but different antibiotics have different side chains attached to this core ring. These side chains determine all of their characteristics, the spectrum of action, how well they penetrate into certain tissues, how they are metabolized, everything. You don't have to know the chemistry behind this, I just want you to know where the name beta-lactams comes from. So okay, penicillins. We've gathered a lot of experience with this group of antibiotics over the course of the last 80 years, so we know all the ins and outs, and to this day, penicillins remain our most trusted and most widely used antibiotics. We all know the story how Alexander Fleming's habit of leaving a messy lab turned into one of the most important discoveries in human history. Penicillin started to be mass-produced in the early 1940s in the middle of World War II, and it changed the world right away. In the pre-antibiotic era, if you got bacterial pneumonia, for example, caused by, you guessed it, Streptococcus pneumococcus, there wasn't much anyone could do. You could only pray that your immune system is strong enough to eventually beat the infection. Unfortunately, for so many millions of people, pneumonia proved to be fatal, and this often included young and otherwise healthy people, not to mention children. And even minor wounds could end up killing a person or result in limb amputation if they got infected. So you can imagine what happened in the battlefield in World War II, where thousands of soldiers got wounded every day. So it's impossible to overstate the significance of penicillin once it became widely available. Potentially deadly infections now turned into a minor inconvenience. Penicillin worked very well against Streptococcus pneumoniae, the main cause of pneumonia, right? And other streptococci like group A Streptococcus, the cause of strep throat, and it also worked well against skin infections caused by Staphylococcus aureus, right? Actually, this is how Fleming first discovered it. In his messy lab, the fungi that produced penicillin, Penicillium molds to be more precise, started to grow on a piece of bread that was left in the lab and contaminated a petri dish that contained a culture of Staphylococcus aureus. The penicillin that the fungi produced killed the bacteria in that petri dish. Today, penicillin comes in oral, IV, and intramuscular formulations. The problem is that in different textbooks you will run into different names for the same thing, which can quickly become frustrating and confusing. So let's straighten this out right away. For me, it's simplest to use the name penicillin G for intravenous penicillin and penicillin V for oral penicillin. The letter V even reminds me of a beak or mouth, so it's easy to remember. A more technical chemical name for penicillin V is phenoxymethylpenicillin, and penicillin G is called benzylpenicillin. In addition to this, penicillin G can also be combined with benzathine and procaine so that it can be administered intramuscularly as a single injection that slowly releases penicillin G into the bloodstream over the course of, let's say, 10 days. Procaine is a local anesthetic, and without it, intramuscular penicillin would really hurt like hell. This single, slow-release intramuscular injection is good enough only for mild infections caused by bacteria that are highly susceptible even to low doses of penicillin, like group A Streptococcus. They are not suitable for more severe infections caused by more resistant pathogens. So, for more severe infections, you will need much higher concentrations, which means you will have no choice but to use intravenous penicillin G that is administered up to 6 times a day, not just once in 10 days, right? Anyway, when it is combined with benzathine, penicillin G is called benzathine penicillin G, obviously, or benzathine benzyl penicillin. With procaine, it's called procaine penicillin G or procaine benzyl penicillin. Actually, in many formulations, there is an equal mix of both procaine and benzathine. But regardless of the name and the formulation, this is all just natural penicillin. And all these versions have the same exact spectrum because they have the same active ingredient, right? So don't let these different names confuse you. If you can't memorize all of them, don't worry, you don't have to. Just notice that all of these names contain the full word penicillin. This is how you know that you are dealing with natural penicillin, because the names of other semisynthetic penicillins that we are about to discuss end with cillin, like oxacillin, nafcillin, amoxicillin, and not full penicillin, right? So when you do see the full word penicillin in the name of a drug, you know that this is a natural penicillin, you know its spectrum of action, and on the package you will see how it's supposed to be administered, so you will figure it out. Nowadays, we mostly use natural penicillins for the treatment of infections caused by group A streptococcus and some other streptococci, maybe mild pneumococcal infections, and for some less common pathogens that I will mention in later lectures. But for most other indications, it has been pushed out by other newer antibiotics, and I will tell you how that happened. But when it first came out in the 1940s, it was truly a miracle, and for a while, it seemed that penicillin could cure pretty much anything. But, of course, it didn't take long before the first problems started to appear. Almost immediately, bacteria started to develop resistance, and within a couple of decades, the majority of strains of Staphylococcus aureus were already resistant to penicillin. Their resistance mechanism was based on the production of penicillinases, enzymes that could deactivate penicillin. Once again, let's make sure that you don't get confused by terminology here. The word penicillinase is often used interchangeably with beta-lactamase. Beta-lactamases are enzymes in bacterial cells that destroy beta-lactams. The beta-lactamases in Staphylococcus aureus we also call penicillinases because they have the highest affinity for penicillins and not other classes of beta-lactams like cephalosporins or carbapenems. You will see in later lectures that other bacteria harbor beta-lactamases that can also destroy various drugs from these other groups. But again, fortunately, beta-lactamases in Staphylococcus aureus are simple, they mainly destroy penicillins. This problem with penicillinases became apparent shortly after penicillin was first introduced. Strains of Staphylococcus aureus that were able to destroy natural penicillins appeared very quickly. In response to this, chemically modified penicillins resistant to penicillinases were synthesized, and they remain the mainstay of treatment for staphylococcal infections to this day. They are called, surprise surprise, antistaphylococcal penicillins. Now technically, there are many drugs within this group, but in the real world, there is usually one or maybe two available on the market in your area. So usually it's oxacillin, cloxacillin, flucloxacillin, nafcillin. All of these antistaphylococcal penicillins come in IV formulations, but cloxacillin, flucloxacillin, and dicloxacillin, so the versions that contain the word cloxacillin, are also oral. But you've probably heard of methicillin. The irony is that out of all antistaphylococcal penicillins, methicillin is no longer produced due to its toxicity, but we've all heard it because its name is still used to classify methicillin susceptible versus methicillin resistant Staphylococcus aureus. As I mentioned a minute ago, nowadays most strains of Staphylococcus aureus, actually about 90% of them, have penicillinases, so beta-lactamases that destroy natural penicillins. So obviously natural penicillins will not work against them. But these penicillinases cannot destroy antistaphylococcal penicillins like methicillin and others. And this is why we label these strains as susceptible to antistaphylococcal penicillins or susceptible to methicillin. In other words, methicillin susceptible Staphylococcus aureus, MSSA. But in addition to penicillinases, some strains have added another completely different resistance mechanism that makes them resistant even to antistaphylococcal penicillins. Therefore, they are classified as MRSA, methicillin-resistant Staphylococcus aureus. I'm sure you are familiar with that name. As a general rule, most community-acquired strains of Staphylococcus aureus are still methicillin susceptible, and most hospital-acquired strains are resistant, meaning MRSA. We will discuss this in more detail in the lesson on skin and soft tissue infections. So what is it that makes MRSA resistant to antistaphylococcal penicillins and by extension all penicillins in existence? Well, in order to kill bacteria, all penicillins bind to the so-called penicillin binding proteins. PBPs are enzymes that are essential for the synthesis of the cell wall of bacteria. Penicillins irreversibly bind to these enzymes and deactivate them. Without these enzymes, the cell wall cannot be built or rebuilt or modified, and without the cell wall, bacteria will simply disintegrate due to a high gradient of osmotic pressure between their intracellular space and the environment. The cell wall is like a sturdy metal net or a fence that is holding the bacterial cell together and preventing it from falling apart. So, with no cell wall, no sturdy cross-links between peptidoglycan chains within this wall, there is no bacteria. Well, in MRSA, these penicillin-binding proteins, PBPs, are modified in such a way that they have a very low affinity for penicillins, including antistaphylococcal penicillins. And if the penicillins cannot bind to them, they cannot deactivate them, they cannot exert their effect. And this is why even antistaphylococcal penicillins do not work against MRSA. It doesn't matter that they are resistant to penicillinases. This is a completely new mechanism of resistance. They cannot even bind to their target. Penicillins, remember this, will never work against MRSA. We need other classes of antibiotics. Fortunately, again, most strains of Staphylococcus aureus, especially the ones outside healthcare settings, are still MSSA, methicillin susceptible Staphylococcus aureus. To summarize, antistaphylococcal penicillins are just like the original penicillin, so they work against streptococci, but since they are resistant to penicillinases produced by Staphylococcus aureus, they are also effective against methicillin susceptible Staphylococcus aureus. Now, you may find in some textbooks that their chemical modifications make them less effective against streptococci than natural penicillin. And yes, technically speaking, they are somewhat less active in vitro. But for all intents and purposes, in clinical practice, most of the time this is irrelevant, and your antistaphylococcal penicillins will work very well against most streptococci, just like ordinary penicillin. This is important for the treatment of skin and soft tissue infections, where you sometimes cannot be sure whether they are caused by streptococci or Staphylococcus aureus, so you need to cover both. The only streptococcus that stands out is again Streptococcus pneumoniae, and you will not use antistaphylococcal penicillins to treat pneumococcal infections, not because they are 100% ineffective, no, but because they are simply better options. More on that in a minute. Speaking of streptococci, do they have any kind of resistance to penicillin? Well, the two most famous members of this family are on the opposite sides of this spectrum. Group A Streptococcus is never, I repeat, never resistant to penicillin. There hasn't been a single strain of this bacterium that is resistant, not one. And this is why penicillin is still the #1 drug for the treatment of strep throat and other infections caused by this bacterium. If the infection is mild, you will choose an oral formulation of penicillin, penicillin V, and if it's sepsis or some other serious systemic infection, you will use intravenous penicillin, penicillin G. When I was a kid, it was common for doctors to inject you with intramuscular penicillin with extended release if you had strep throat, and you only needed one injection, but it hurt like hell. Remember, this is why intramuscular penicillin G contains procaine, a local anesthetic, to numb the pain at least a little bit. Okay, so what about other streptococci? Well, some of them did develop a degree of resistance to penicillin, but get this. Streptococci do not develop resistance or decreased sensitivity to penicillin by producing penicillinases like Staphylococcus aureus. No, what they do is they modify their PBPs, penicillin binding proteins, kind of like MRSA. With these modifications, their PBP's affinity for penicillin drops, meaning it becomes less likely that the molecule of penicillin will bind to this particular PBP and disable it. So, in essence, again, the mechanism is similar to the way MRSA protects itself from penicillin, but with one crucial difference. As opposed to MRSA, most of the time, streptococci do not get 100% resistant to penicillin. Instead, they develop only a partial resistance, meaning penicillins can still work against these partially resistant cocci, but at higher doses. And this is important for us in clinical practice. If we know that there is a substantial likelihood of resistance, we need to increase the dose of penicillin. And that makes sense, doesn't it? Imagine it like this. Let's say that these modified PBPs in partially resistant strains won't bind to a molecule of penicillin every single time they're exposed to it. Instead, they will bind 50% or 20% of the time, meaning on average every other or every fifth molecule that bumps into the PBP will bind to it and disable it. So how do we increase the likelihood that something will bind? Well, by absolutely flooding this PBP with as many molecules of penicillin as possible, and hopefully one should stick according to the probability, right? So the more there are, the more likely it is that one will bind to the PBP and disable it. So the way to deal with this resistance mechanism by some streptococci, and especially Streptococcus pneumoniae, is to increase the dose of penicillins. But with oral penicillins, can you always do that? Obviously, from the way I asked the question, you probably can't, right? The first problem is that many oral penicillins are very poorly absorbed from the gut, meaning that in order to achieve higher concentrations in the lung or the sinuses or wherever the bacteria may be, the patient would need to eat a bucket of penicillin. That, of course, doesn't work, it's ridiculous. There is only so much the gut can absorb, not to mention toxicity and side effects. So, wouldn't it be great if there was a way to make penicillin more bioavailable, more absorbable? Well, in the 1960s, Aminopenicillins came out. They have an amino group attached to the basic structure of penicillin. You can even see it in their names: ampicillin, amoxicillin. Ampicillin is intravenous and amoxicillin can come in intravenous and oral formulations. Amoxicillin is much better absorbed from the gut than your standard penicillin V. You can give your patient a higher dose, which will result in a higher concentration in the blood, the lungs, the sinuses, and wherever the infection is. Therefore, amoxicillin, especially with higher dosing, can even cover the strains of Streptococcus pneumoniae that are partially resistant to penicillin. And this is why in many guidelines you will see amoxicillin, not the simple penicillin, listed as the first-line treatment for all respiratory infections caused by pneumococcus, like community-acquired pneumonia, otitis media, and acute bacterial sinusitis. Just notice that different guidelines will recommend different doses of amoxicillin depending on their local resistance rates of pneumococcus to penicillins. So, in areas where most pneumococci are still highly susceptible to penicillin, like in the UK for example, the standard dosing of amoxicillin is good enough. In some countries, even simple penicillin V is good enough. But in areas where partial resistance of pneumococcus to penicillins is higher and more common, like in the US, you will see that higher doses of amoxicillin are recommended, especially for high-risk patients with more severe symptoms. More on that when we discuss respiratory infections specifically. Now, if it works very well against pneumococcus, the king of this streptococcal resistance, it makes sense that amoxicillin will also work very well against other streptococci. Another advantage of amoxicillin is that modern formulations generally taste a lot better than your standard penicillin V. And if you are a pediatrician or you have your own kids, you know what I mean, and you deeply appreciate how important this is. So okay, amoxicillin will work great against streptococci. What about staphylococci? You remember that most strains of Staphylococcus aureus nowadays have penicillinases. Well, despite being more soluble, achieving higher concentrations and everything, amoxicillin is still vulnerable to deactivation by penicillinases, right? And now you may be asking, okay, so can we modify it, just like we did with penicillin, to make it more resistant to penicillinases? Well, unfortunately, no, not without jeopardizing everything that makes it great in the first place. But there is something else we can do. We can mix it with a substance that will neutralize the penicillinases. And now we come to one of the most used and abused antibiotics around, amoxicillin-clavulanate. In Europe, it exists in oral and IV formulations, but in the US, it's only available as oral formulation. So, amoxicillin is amoxicillin, and clavulanic acid, is a penicillinase inhibitor. So, amoxicillin-clavulanate will work very well against streptococci, obviously, because it has amoxicillin, but it will also work against wild-type staphylococci, methicillin-susceptible Staphylococcus aureus, but of course not MRSA, just like any other penicillin. And just like we combine amoxicillin with clavulanate, we also combine ampicillin with its beta-lactamase penicillinase inhibitor. In this case, it's sulbactam. So amoxicillin is combined with clavulanic acid and ampicillin is combined with sulbactam. Their spectrum of activity is virtually identical, but ampicillin-sulbactam comes only in IV formulations. Okay, now that we know how penicillins work against gram-positive bacteria, it's time to see how they work against the gram-negatives, and the answer is they don't work very well, because there is a fundamental difference in the structure of gram-negative versus gram-positive bacteria. Gram-positive bacteria have a very thick cell wall. Gram-negatives, on the other hand, don't. Theirs is very thin. And now you might be thinking, okay, so where is the problem? Well, the problem is that outside of this thin wall, gram-negative bacteria have an extra layer of membrane, like another cell membrane. And for antibiotics, this is an absolute disaster because most antibiotics, especially penicillins, are water-soluble, and membranes consist of lipids. Therefore, it's very difficult for molecules of penicillin to penetrate this outer membrane and get to the cell wall like they would in gram-positive bacteria. So, natural penicillin is generally not very effective against gram-negative bacteria. But, fortunately for us, once again, aminopenicillins come to the rescue. Their chemical structure makes it easier for them to go through the outer membrane and reach the PBPs on the inner side on the cell wall. Problem solved, right? Well, of course, it's never that simple. There's another problem, and by now you probably guessed what it is. Nowadays, most gram-negative bacteria have penicillinases. Therefore, even though aminopenicillins can penetrate the outer membrane, they will be annihilated before they have the chance to exert their effect. But if they are backed up by a penicillinase inhibitor like clavulanic acid or sulbactam, this might restore their activity. So today, some gram-negative bacteria will be susceptible to pure aminopenicillins, but most will have a penicillinase and they will require the addition of a penicillinase inhibitor. Now, will the inhibitor work every single time? The short answer is no, because there are numerous different penicillinases and not all of them are equally inhibited by penicillinase inhibitors. Again, you will need to take a look at your local resistance rates. In some areas, penicillin-penicillinase inhibitor combinations will be great for the empiric coverage of infections caused by gram-negative bacteria, but in other areas, even that won't be enough. More on that when we discuss these specific infections. For now, let's just understand this logic. To work against gram-negative bacteria, a penicillin-based antibiotic first needs to pass through the outer membrane. Next, it has to be protected against penicillinases that are usually present. This is true for E. coli, our most typical and most common gram-negative pathogen, and for many others. And among these others, there is one that stands out. You guessed it, Pseudomonas aeruginosa. Remember, this bacterium is intrinsically resistant to many antibiotics, and there are many reasons for that. Its outer membrane is even more impenetrable than the membranes of other gram-negative rods. Not even aminopenicillins can get through this. It also has special efflux pumps that pump out antibiotics even if they do make it through the outer membrane. This is true for penicillins and for many other classes of antibiotics. Its spectrum of resistance is so vast that it influences the very way we classify antibiotics, and the ones that at least have a chance of working against Pseudomonas get the title of antipseudomonal antibiotics. Among penicillins, the one that is able to penetrate its defensive layers is piperacillin. This is the one that is most well known and most widely available. And since piperacillin works against Pseudomonas, the king of gram-negative resistance, right? It makes sense that it also works against many other less resistant gram-negative bacteria as well, like E. coli and others. Amoxicillin and ampicillin are not anti-pseudomonal, no matter what kind of beta-lactamase inhibitors you add to them, because they simply cannot penetrate this outer membrane. They have absolutely no activity against Pseudomonas, remember this. But piperacillin does. However, even though it penetrates the outer membrane very well, piperacillin is still a penicillin and it's susceptible to destruction by penicillinases. To a lesser extent maybe than other penicillins, but still it needs a wingman, it needs backup in the form of a penicillinase inhibitor. And in the case of piperacillin, this is not clavulanic acid, this is not sulbactam, it's tazobactam. And this combination, piperacillin-tazobactam, is something you are certainly familiar with. It's one of the most overused IV antibiotics around, because it covers streptococci, methicillin-susceptible staphylococci, most gram-negative bacteria, at least for community-acquired infections, and many strains of Pseudomonas, of course. As a side note, penicillinase inhibitor combinations also cover most anaerobes, so with these drugs you get an extremely wide coverage, and this is why they are so beloved, but unfortunately also overused. So okay, this is the basic classification of penicillins, with the most widely used and most important representatives. As always, you can download the PDF summary of this lesson on my website for free. The link is in the description. With this overview of penicillins and the first lesson on the most common bacteria, you will have no problem mastering all other classes of antibiotics and learning how to use them in practice with competence and confidence. The two videos you just saw are the first two lessons in my online course about antibiotics that I designed specifically for clinicians. So, if you feel that you already learned something valuable, wait until you see the rest of the course. If antibiotics are something you struggle with, this will be a true game changer. I think that you will even surprise yourself with the level of skill that you will acquire. For more details about the course, check out the link in the description and I hope I see you there. Take care.